All right, let's dive into the world of inflammatory bowel disease, or IBD. Now, you've probably heard of its two heavy hitters, Crohn's disease and ulcerative colitis. They're in the same family and they can feel pretty similar, but trust me, they are two totally different characters playing on the same field. And understanding why that matters, well, that's everything.
So that leads us to the big question, right? If they're both chronic inflammatory gut conditions, what is the actual difference? This isn't just trivia. Getting this right is absolutely critical because the answer changes everything from how doctors diagnose it to the treatments a person gets. Okay, let's get into it.
First up, let's meet Crohn's disease. We're calling it the chaotic skipper, and for a very good reason. Its whole personality is unpredictability. It kind of just does what it wants, where it wants, with no clear rulebook. Get this, Crohn's can pop up anywhere in the entire GI tract. We're talking from the very beginning to the very end. But the real giveaway, the key to its whole identity, is that last part, a discontinuous pattern. That's the phrase that truly sets it apart and makes it so tricky. Yep, this is its calling card. You see, instead of one long, continuous stretch of inflammation, Crohn's attacks in patches. It'll hit one spot, skip a perfectly healthy section of tissue, and then hit another spot further down. That's why we call it the skipper. And those inflamed patches, they have a name, skip lesions. A good way to picture it is like a cobblestone path where some stones are broken and crumbling, but right next to them are perfectly fine, healthy stones. That's what the inside of the bowel can look like with Crohn's, this patchwork of sick and healthy tissue, all mixed together. So how do doctors actually spot this? Well, they're looking for some very specific visual clues on scans. There's cobblestoning, which makes the wall of the bowel look all bumpy and irregular, just like an old street. Then you have the famous string sign. That's a really severe narrowing of the intestine. And sometimes, if it involves the stomach, you might even see something called a ram's horn deformity. These are like the fingerprints Crohn's leaves at the scene.
Okay, now for our second contender, ulcerative colitis, or UC. And if Crohn's is chaos, well, UC is the complete opposite. We call it the methodical climber because its path is totally predictable, it's consistent, and it follows a very specific route every time. And right away, the difference is just crystal clear. First, look at the location. UC is stuck only in the colon and rectum. That's it. And second, its movement. It always starts at the bottom and climbs its way up. There's no skipping, no jumping around, just one continuous unbroken path of inflammation. So here's the bottom line. Where Crohn's jumps, UC climbs. It's this relentless, uninterrupted line of attack. And that one simple fact changes literally everything about how this disease shows up and how you deal with it. And of course, UC has its own famous visual sign, the lead pipe appearance. What happens is, after a while, all that inflammation causes scarring, or fibrosis, and it makes the colon wall all stiff and smooth. It loses all its natural healthy folds, so on an X-ray, it honestly just looks like a straight, featureless pipe. And you want to talk about predictable? Get this. 95% of all UC cases start in the exact same spot, the rectum. For a doctor trying to figure out what's going on, that kind of consistency is a huge clue. Okay, so we've met the chaotic skipper and the methodical climber. Now it's time for the main event, the showdown. Let's put them side by side and make these differences impossible to miss. This chart just lays it all out, doesn't it? You've got the skips of Crohn's versus the continuous spread of UC. Crohn's can start anywhere. UC is almost always in the rectum. Now, check out the lymph nodes. Enlarged in Crohn's is pretty normal. Not so much in UC, and that is a super important detail we're going to come back to. Fistula, those are like abnormal tunnels between organs, are common in Crohn's but super rare in UC. Even the little valve between the small and large intestine is different, often narrowed in Crohn's but wide open in UC. Look, if you only remember one thing from this whole explainer, let it be this right here. Crohn's skips, UC is continuous. That is the fundamental difference that drives almost everything else we see between these two conditions. So we've gone over what makes them different. But that leads us to the most important part of this whole conversation. Why? Does any of this matter? Why is it so incredibly important for doctors and patients to know which is which? Because, and this is crucial, this is not just some academic exercise for a textbook. Getting the diagnosis right has huge real-world consequences. It impacts medication, it impacts surgery, and
maybe most importantly, it impacts how doctors screen for long-term risks, like cancer. Now listen to this quote from our source material, because it really drives the stakes home. If you see a big lymph node in a UC patient, you have to think that it might be cancer. That's a powerful reminder that telling these two apart can be, quite literally, life-saving.
So let's connect the dots. Remember the table? In Crohn's, seeing enlarged lymph nodes is just an expected part of the inflammation. It's business as usual. But in UC, it is not typical at all. So if a doctor sees that in a patient with UC, a huge red flag goes up and they have to immediately start thinking about a much more serious problem. That's why the distinction is so absolutely vital. So there you have it. One family, but two completely distinct identities. And the better we get at understanding their unique personalities and behaviors, the better we can get at creating specific, tailored treatments. So the big question I'll leave you with is this. As our understanding gets deeper and deeper, how is this going to completely revolutionize the future of